Hi, this is Brian Kim. I'm going to share with you case number 280 in the Best Way to Do Cataract Surgery series. And the title of this series is not to suggest this is the best and only way, but to get you to think critically of your technique so that you can provide the very best for your patient. So this is a patient who has post-radial keratotomy, and the patient's going to get a toric lens. And this is a soft lens. You're going to see double chop, cross chop, mechanical fracturing, and zero ultrasonic energy use by leveraging manual cutting, using my two hands to crush the lens into smaller pieces and emulsify the lens piece. Again, using the Veritas, great aspiration and vacuum power on this machine. So this is a corneal marker which will help me to center and size the rexus. I make my paracentesis incision first on the right side and then the left side, making sure I'm parallel to iris plane, which creates a nice corneal shelf, which will allow me to achieve a self-sealing incision. This is intracameral epinephrine, and then some dispersive viscoelastic. And then using the Orlock technique, I'm twisting the cannula, the viscoelastic cannula, to control the eye, pulling the eye down. This is a patient with a Bell's reflex. And this is a 2.4 millimeter incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel, and then I enter. Using that same cannula and maintaining the Orlock technique to control the eye, I switch to the microrexus forceps, puncture the center, pull down, grabbing the right side of the tear, going around circumferentially, again, controlling the eye with the cannula with the other hand. Again, I'm always leveraging and trying to maximize control whenever I can, using two hands whenever possible to control the eye as I make my rexus. And by doing it this way, I'm able to achieve a well-centered and sized rexus without any difficulty and without any trouble. This is the capsule fornix hydrodissection technique. I place a cannula under the rexus edge contra-incisionally, point the tip down, get a nice wave, lift the lens up, decompress the bag, pushing down on the lens, sweeping under the rexus edge, under the left side, and then the right side. You can see the lens begins to spin now. Turning on infusion, lifting the incision with the chopper, going in with irrigation off to minimize Decimase trauma, turning on infusion, releasing some pupillary block with the chopper, removing the surface epinuclear material, sliding the chopper under the rexus edge contra-incisionally, turning the phaco tip vertically sub-incisionally, fracturing the lens in half, and that is the double chop, sliding the chopper under the right heminucleus and pulling it centrally toward the phaco tip, and that is a cross chop. Using some vacuum to lift that first quadrant up, crushing the lens piece with the chopper against the phaco tip, and then aspirating and removing the lens piece. Again, the fluidics is very good with this machine. Excellent chamber stability, nice deep chamber without any trampolining whatsoever. Excellent purchasing power of this machine. I'm able to grab the lens pieces very easily, pulling the lens pieces up. I rarely see it slip off. Unfortunately, there are other machines where you try to grab it and it just slips right off the tip, and that is just not the case with this machine. Excellent purchasing power, holding power, and then fracturing the lens piece, crushing the lens piece with the instruments. Again, this is a zero ultrasound case, and the high vacuum is able to just suck and collapse the lens pieces into the phaco tip very easily. Aspirate the epinuclear material, and that is the end of the nuclear removal. So I take the chopper out, push PSS in, take the phaco tip out, and then go in with the ironing handpiece. I start sub-incisionally, peeling off the cortical material from anterior to posterior, trying to remove that fine wispy material as well. Being very careful, using the cortex mode, using foot pedal control, trying to remove any stragglers of cortical material there. Switching to polish mode, polishing the posterior capsule, polishing under the rexus edge, pulsing BSS into the subincisional capsule fornix. It looks pretty clean. Turning off infusion and then pushing cohesive viscoelastic to fill the bag. Taking the ironing handpiece out and switching to the sweeper. Sweeping under the rexus edge, first on the left side and then the right side. You can see the fine lens material being swept off. So this is a toric lens. This patient has 8 RK cuts. You saw I made my main incision between the RK cuts. The only time it's okay to use a toric lens in the context of an RK eye is pretty simple. If they're able to be refracted to close to 20/20, that means that they have regular astigmatism and not irregular astigmatism. So a toric lens can be helpful to reduce that astigmatism and help the patient see better without spectacle correction. I go underneath the lens, removing the viscoelastic from within the bag. Push the lens back down into the bag, sweeping under the rexus edge. And then I'll have to align this lens. I always go to low mag in this situation. And then using my ring, I'm trying to find the appropriate axis. And with infusion on, you're able to turn this lens either clockwise or counterclockwise. This lens is a little bit more sticky. The ZC-BU platform is a little bit stickier, a little bit more resistance to turning compared to the Acrosoft material, but I'm able to position it without any trouble. And this ring that I'm using, it's a very thin profile axis ring, and I get it from Epsilon, and I don't have any financial interests in that ring, but I really like that ring. I'm able to position that lens on the appropriate axis. Again, turning on infusion, which allows the lens to turn, and the capsular bag is nice and inflated, and you're not snagging the capsular bag as you're trying to rotate the lens. If the capsular bag is snagged, then you're not actually moving the lens, you're just rotating the bag, which is not really helpful because it's going to just go back to the location that you had it before. So as I come out, I push infusion in, hydrate the incisions, and that's the end of the case. So again, zero phaco energy using manual fracturing forces using the chopper and phaco tip with the double chop and cross chop. And this is aided by a machine that has excellent chamber stability and excellent aspiration and vacuum, excellent holding power. I'm able to aspirate the lens materials so easily. It just collapses into the phaco tip without any trouble. This soft material, it just sucks very easily with this machine, very strong fluidics. And then I place this toric lens with infusion on, trying to align the lens. And remember, when you have a toric lens in RK, the key component in being able to use a toric lens in the context of RK is if the astigmatism is regular. So if you use a topographer and you see that the astigmatism is regular, and you do a refraction and you can see that the amount of cylinder is somewhat similar to the refraction as well as to the topography, and that the patient is refractable close to 20/20, this tells you that the astigmatism is regular and not irregular, and therefore a toric lens will be beneficial. And this patient had excellent vision after the surgery. Again, 20/20 vision, uncorrected, post-op day 1, with a crystal clear cornea with zero ultrasonic energy use, leveraging mechanical fracturing techniques with the double chop and cross chop technique. So I hope this was helpful to you, and I thank you for your attention.